Welcome to the Early Childhood Voices Conference. My name is Dr. Michelle Brown, and I'm presenting today on behalf of Siana Heath, Erin Bowcock, and Chris Barnett from ORS Australia. And our presentation is titled Positive Outcomes for Allied Health Professionals, working together to support children with multifaceted needs. Let's begin with an acknowledgement of country. I'm recording this presentation from the lands of the Wiradjuri people. We acknowledge the traditional custodians of the various lands on which we work and the Aboriginal and Torres Strait Islander people participating in this session today. We pay our respects to elders past, present and emerging, and together we celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. The learning outcomes from this presentation are to examine the importance of working collaboratively when supporting children accessing early intervention who have multifaceted needs, to investigate clinicians' perspectives towards working collaboratively and current workplace practices, to critique the perceived barriers and facilitators reported by clinicians, and to evaluate how we can support clinicians with the perceived barriers and facilitators to enable them to maximise outcomes for early intervention clients with multifaceted needs. The term working collaboratively is a working term, and there are a number of different definitions and ways to describe it, as we can see in the literature. It is reported to often be used, the terms that are used to describe are often used interchangeably and are often not clearly understood. For this presentation, we're going to use the broad overarching term of working collaboratively, which has been described as working together in partnership with the child and their significant others to maximise client outcomes. And it sees that partnership working together throughout the continuum of care. So from assessment to goal setting and therapy planning, implementation of the therapy and evaluation of the therapy as well. The three main terms that are used to describe working collaboratively are multidisciplinary practice, interdisciplinary practice, and transdisciplinary practice. However, there are a number of other terms that are used as well. Multidisciplinary practice sees each discipline maintaining their discipline-specific boundaries and having their own goals. However, the teams work together and collaboratively to achieve an overarching common goal. However, this is achieved through individual discipline-specific goals. Interdisciplinary practice sees one overarching goals and all disciplines working within their discipline-specific boundaries. However, it is towards that goal. There are not discipline-specific goals as well. It is the one goal that they are working towards. Transdisciplinary practice is where that discipline-specific roles are removed and all clinicians are working within the same role to achieve that same goal. So no longer having the discipline-specific boundaries. Underpinning all of the different terms and ways that are used to describe collaborative practice is that driver for it to be family-centred, so seeing the child and the significant others as the driver of the approach that is taken, and also for it to be based on evidence, so using that evidence-based practice. We know that this is particularly important for early intervention children who have a number of factors that are going on and who need holistic, high quality and coordinated care to help them achieve their goals and reach their fullest potential. We also know that from a team perspective, for successful interdisciplinary practice, we need each team member's unique contribution to be understood, valued and respected. And the World Health Organization recommends interdisciplinary practice where there is one goal and each different discipline is working together to achieve that goal but maintaining their discipline-specific roles. And as I mentioned before, this is particularly important for children accessing early intervention and who have multifaceted needs. So the NDIS has changed the age range of what they term as early intervention, and it is now from birth to 9 years of age. And we're also seeing a movement away from the term complex to multifaceted. And that's because of the negative connotations that are often associated with the word complex, suggestive that the child or their significant others are complex, when rather it is that the child or the significant other have multiple needs that need to be supported. This, of course, links back to the rights of the child in Article 13, where we want to see children being able to have that freedom of expression to express themselves in any means possible, so that they're able to communicate with others, and of course the development of the child's personality, talents, and mental and physical abilities to reach their fullest potential. And this is a strong driver, that Article 29, and empowering children and their significant others to reach their fullest potential, is a strong driver of ORS. So ORS is the organisation that conducted the study that we're discussing today, and it is an allied health service provider. And its strong driver is to empower clients to reach their fullest potential and to be client-centred in the approach that is taken. ORS supports clients across the lifespan from birth right through to older adulthood, and it's been supporting clients and their significant others for over 30 years. It's the largest and fastest growing national allied health and workplace rehabilitation provider, one of in Australia, and it's an NDIS provider. And ORS has a very strong vision to ensure that we provide high quality support to clients and their significant others. And one of the ways that we do this is through high quality training, supervision, education, and support. So the aim of this study was to evaluate the outcomes for allied health professionals who work at ORS and who are working collaboratively to support early intervention clients with multifaceted needs. So we designed a questionnaire in collaboration with an interdisciplinary team, and it was designed to capture questions from a number of different ways. So we had Dropbox responses, we had rating scale, and we also had open response questions so that we could really collect richer data and get more of a perspective of what the clinicians are thinking towards working collaboratively. The questions focused on perceptions of collaborative practice and current practices as well, as you can see from the bar graph just over there. Pie graph. And it was designed to be anonymous, so less than 10 minutes. That had 19 questions, and we used the SurveyMonkey online platform. So we'll start off with having a look at the rating scale questions and considering what the clinicians perceived, how they perceived working collaboratively and their thoughts towards that. In terms of the participants themselves, so we had a number of different disciplines participate. ORS has also recently had dietetics join our team. However, they hadn't joined by the time that we conducted this research, but we're hoping for future studies that dietetics will be involved as well. As you can see there, then the majority were positive behaviour support practitioners, followed by speech pathologists, occupational therapists, psychologists, and physiotherapists. And we had 29 clinicians participate in the study. As early intervention is a relatively new area that ORS has been providing support in, we weren't able to tease out the exact number of clinicians who are actually providing services to early intervention clients from those who are not. So we weren't able to give a comparison of what that represents within the organisation, but there were 29 who participated in the study. And they were managers or team leaders from ORS, and they supported children, so children who are less than 9 years of age with multifaceted needs, and they worked with one or more other discipline from ORS. The workplace locations were 3 from the ACT, 15 participants from New South Wales, 1 from Victoria, 9 from WA, and one of the participants had multiple offices, so not one office that they considered their own. In terms of qualifications, befitting with having managers and team leaders participate in the study. As you can see, they all had an undergraduate degree or a master's degree, and they'd been practicing for a number of years. There weren't very many who were in that early career stage. And in terms of which disciplines they were collaborating with, the majority was with positive behaviour support, followed by occupational therapy, psychology, speech pathology, physiotherapy, and exercise physiology as well. And we wanted to capture the number of clients that the clinicians were currently seeing who were early intervention clients and had multifaceted needs that they were also supporting via collaborative practice. And these were clients who they were currently seeing, so they weren't on a waiting list, they were receiving services at that point in time. And as you can see from that bar graph just there, the majority had between 1 to 5 early intervention clients with multifaceted needs who they were supporting with another discipline at ORS. So this doesn't include disciplines outside of ORS. So I'm now going to have a talk about the findings from the study, and this first one is looking at the rating scale responses. So the ratings were from 0 to 100, and clinicians were able to put in how they thought, what they rated a particular question, how they thought it rated from 0 to 100. And as you can see here, there are very high and very positive results. So most of the clinicians perceived collaborative practice to improve understanding of different disciplines with the average of 95. This ranged from 29 to 100. The clinicians also perceived collaborative practice to facilitate better outcomes for clients who are accessing alternative care, such as out-of-home care. So again, a really high response say that they thought collaborative practice was positive and supported these children who were accessing alternative care. This was the same for family-centred practice and evidence-based practice, where the clinicians perceived collaborative practice to facilitate and support family-centred practice and evidence-based practice. And then finally, given all those other positives, this fits quite well, that the clinicians considered collaborative practice to be important for supporting early intervention clients with multifaceted needs. We did, of course, see quite a range, and there were outliers, but I have included it in that range of scores. So from, as you can see there, majority from 50 to 100 for family-centred practice, evidence-based practice, and importance of collaborative practice as well. This suggests that the clinicians perceived collaborative practice to support a number of different positive benefits for the client and achieving the type of care that we're providing. In the open responses, we were able to really tease out the barriers that were reported by the clinicians to get a better understanding of what are the barriers involved in working collaboratively. And you can see from the pie graph there that the biggest barrier was, of course, the time restraints and scheduling appointments, as I'm sure a number of clinicians who are watching today can relate to. This was followed by communication with team members and understanding of roles and responsibilities. There was also responses to differences in approaches to intervention and assessment, and of course that need for clear policies and procedures. We had six participants who skipped this question, and 23 answered it. And I've got here some quotes that captured, which did a great job of capturing the other quotes that were written within the open responses. So it can be difficult with many personalities and passions to reach a common goal without the bias of ego, keeping up with everything and everyone. Interdisciplinary approaches only consistently succeed when there is a system in place to support shared assessment, information gathering, goal setting, implementation planning, communication and evaluation, understanding of roles and responsibilities, ensuring that consistent, clear communication of the therapy plan and activities are communicated to the client and support network by all members of the team. And of course, the time one, the most challenging factor is getting the same time to meet and work on those goals together. There were a number of enablers and facilitators that the clinicians reported as well. Once again, we did get a number of clinicians skipping this question. We had 7 skip and 22 answered it. And as you can see there, the strongest enabler was facilitating positive outcomes for clients, and this was then closely followed by working holistically. So not only just focusing on that body structure and function of the International Classification of Functioning, but thinking about the activities and participation, the environmental factors, the personal factors as well. We also saw learning from colleagues as a strong facilitator and the efficiency that working collaboratively provided. And just a couple of quotes here to capture what their clinicians reported. So, learning from each other while supporting the client to achieve their goals, being able to share ideas and get other perspectives into issues clients face. This allows us to truly tailor their care to what will work specifically for that client to achieve the best outcome. Teamwork with a smiley face. Providing clients with the best possible care that is aimed at their specific goals and encompasses all of their needs in one place so that clinicians can communicate and provide the highest care. So what are the implications and conclusions from the study? How does it have an impact for clinicians who are supporting early intervention clients who have multifaceted needs? Well, the first is that there were positive perceptions reported by the clinicians towards working collaboratively. The clinicians perceived working collaboratively as strengthening their application of family-centred practice and evidence-based practice. So linking back to the type of care that was provided. Clinicians also perceived working collaboratively as a facilitator for better client, so better child outcomes and for better outcomes for the significant others. So overall client and significant other outcomes. And the clinicians also perceived working collaboratively to increase understanding of the scope of practice of different disciplines, so overall clinician outcomes. The clinicians from a variety of different disciplines who participated in the study saw the benefits for the client, the clinician, and the overall type of care that was provided to the child and the significant others from working collaboratively. The findings are consistent with the literature, which highlight that time restraints, communication, and unclear understanding of roles and responsibilities are key barriers. One barrier that didn't come up in our research, however, does come up in conversations at ORS is, of course, funding. And this is a barrier which is often reported in the literature as well. In terms of the enablers, the facilitators for working collaboratively, consistent with the literature, the study found that working collaboratively, the clinicians found that enhanced care and outcomes for the child and their significant others. So that was their perception, that it improved outcomes for the child and the significant others, and that it built clinician capacity as well as lifelong learning. So what does this mean for our practices with children and their significant others? Well, working collaboratively is valued and perceived as improving outcomes for the child and their significant others, improving outcomes for the clinicians, as well as models of practice. However, we know that it also requires time and that it needs policies and procedures to ensure that roles and responsibilities are clearly identified and communication pathways are established. Everyone knows what is expected of them, when and how. We also know that working collaboratively has positive implications for children and their significant others and for clinicians. It promotes stronger outcomes for the children and their significant others from working holistically to achieve a common goal, and while doing so, building clinician capacity and learning while they learn from each other. So the take-home message that we would like to end with today is that we at ORS want to see children with multifaceted needs who are accessing early intervention care reach their fullest potential. The findings from this study indicate that by working together, we can support children and their significant others by reaching their goals and building clinician capacity and lifelong learning. If you'd like to find out more about ORS, or have a chat to us about this study, you can contact us. Email addresses are there, or you can head to www.orsgroup.com.au. Thank you for your time.